I'd like to tell you about one of my patients. I'm going to call her Agnes. Agnes was 50 years old, a widow, mother to three lovely children, aged 25, 18, and 12. So one evening, Agnes went to sleep, feeling perfectly fine. But the next morning, she just couldn't get out of bed. She couldn't move. She couldn't talk. She was in a coma. During the night, Agnes had had a stroke. We found out later that the type of stroke she had left her in what we call a locked-in syndrome. So while she couldn't talk, couldn't move, the rest of her brain was working perfectly fine. Imagine being able to hear everything that's being said to you and about you. Being able to understand everything that is happening to you. Being able to feel everything that is happening. And just not having a way of communicating to the outside world. Being diagnosed with any condition that could potentially take your life can be devastating, both to the patient and to the family. It doesn't matter if this is something sudden and unexpected, like a stroke or even COVID, or something that is more chronic, like cancer, heart failure, kidney disease. For a long time, even for me as a healthcare worker, knowing that one of my patients had a diagnosis that would eventually take their life was scary. I was not equipped with the skills I needed to have those types of conversations. How do you even have a conversation like that and not take away all of your patients' hopes? It felt as if admitting it to myself meant I had failed at my job. And this is true for a lot of healthcare workers. Our culture in Zambia and in Africa in general also does not make it easy to have these types of conversations about life, illness, and death, even when death is a very real possibility. How many of us here, if we had a diagnosis that would take your life, would want to know? What if it was a loved one, your spouse, your parent, your child? Would you want to know? Would you want them to know? So what tends to happen is between the patients, families, and the healthcare system, we engage in a kind of a conspiracy of silence. A don't ask, don't tell kind of relationship, where they feel as if they can't or shouldn't ask, and we don't tell. We hope that maybe by not talking about it, we can avoid death, or at least delay it. Our cultures and our beliefs tell us that by talking about death, we bring it closer. After a lot more learning on my part, I came to certain realizations which I would like to share with you. The hard truth is, no one gets out of life alive. But sometimes what we're given is an opportunity to change the way we think and talk about life, illness, and death. A note in one of my patients' files reads, "There's nothing more we can do." That's usually where I get called in. As a palliative care provider, part of that is end-of-life care. But palliative care is so much more than that. It's about working with patients and families to help them define what is important for them as they approach the end of their life. As human beings, we have 4 basic dimensions that are interconnected, that define us. The first is probably the easiest one to think about. We are physical beings. We want to be healthy. We want to be free of distressing symptoms. We want to be free of pain. There's a Zambian phrase that says, "Ichikalipa chishibomwine." Only he who is in pain knows their pain. But what we can do is, by talking about the pain, help them deal with the pain and be pain-free, even towards the end of their life. We're also very emotional beings. We are people with hopes and aspirations. And then illness comes along and changes that completely, replaces them with fears and anxieties, even depression. And those emotions, if not dealt with, can actually make the physical symptoms so much worse. And so it's important that patients and families know that it is safe and okay for them to talk to us about what they are feeling and get the help they need. As Zambians and Africans in general, we are very social. We are husbands and wives. We are brothers and sisters. Illness changes our roles. We go from being heads of households to being dependents. And that can be very distressing. We worry about what happens when we're no longer there. We worry about being a burden to our families. And if that is not addressed, it can also make what we are going through so much worse. We are a very religious people, very spiritual, and it is such a source of hope in our lives, a hope for a miracle, for recovery, or at least a hope for the afterlife. But sometimes our religions and our beliefs can also be barriers to how we access care, preventing us from seeking help when we need it, even accepting help when it is offered. We may feel guilty about what we're going through, and we may take that until we take our last breath. Talking to people about life, illness, and death is not easy. And yes, it is very important, that we acknowledge whenever we or a loved one has a terminal diagnosis. But it is far more important that we recognize that while we may not be able to add any more days to their life, we can always add more life to the days that they have left. And that is what palliative care is about. It's about working with patients and families to define what's important for them. It's about making sure that they understand what is happening to them and they are part of the decision-making process. It's about making sure they are free of pain, even at the end of life. It's about taking the opportunity to heal relationships, to say what needs to be said in their own words. It's also about taking the opportunity to prepare ourselves for what comes next, whatever we may believe the next stage of our life to be. My patient Agnes died after a week in the hospital. But in that short time, we were actually able to find out that we could communicate to her. We could talk to her. She could blink once for yes and twice for no. And in that small way, she was able to tell us whenever she was in pain, which we treated. But more importantly, she was able to talk to her family, her children, knowing that every word of love they shared with her, she was able to hear and understand. And every comforting touch that they gave her, she felt, and they knew that she was there. What I have learned through all of this is that when we see our patients, our loved ones, as people first, and not just the diseases they have, even at the end of life, there is always something we can do. Thank you.